Hello again. This is Module 3, Part 2 of Systemic Diseases and Their Ophthalmic Manifestations. Presentation by Jacob McGinnis, adapted from the Essentials of Ophthalmic Nursing by the American Society of Ophthalmic Registered Nurses. To reiterate the educational objectives for this module, 1 is discuss the signs and symptoms of the ocular manifestations of acquired immune deficiency syndrome. 2, identify at least 2 congenital disorders with ocular manifestations. 3, list at least 4 ocular manifestations associated with diabetes mellitus. 4, differentiate between the ocular manifestations of the herpes simplex and the herpes zoster virus. 5, describe the ocular manifestations of 2 systemic autoimmune conditions. 6, discuss the ocular pathologies related to 2 hematologic disorders. And 7, identify the signs and symptoms of the ocular manifestations of toxoplasmosis. Lymphoma. Its definition is that lymphomas are a heterogeneous group of malignancies that arise from the clonal proliferation of B cells, T cells, and natural killer cell subsets of lymphocytes at different stages of maturation. Its pathology is that different stressors in the form of infectious, inflammatory, and toxic factors interact with the genetic makeup of the human host in a complex manner to result in lymphomagenesis. One of the widely accepted principles of lymphomagenesis is being on long-term immunosuppressive therapies, which make the innate immune system less able to detect and destroy cancer cells or ward off infections that could result in cancers. Its etiology: different environmental, infectious, and genetic factors have been identified which predispose people to lymphoma. Occupational exposures include herbicides and pesticides. Infectious organisms, these include Helicobacter pylori, Borrelia burgdorferi, Chlamydia psittaci, and Campylobacter jejuni, human T-cell lymphotrophic virus, adult T-cell leukemia and lymphoma, hepatitis C, human herpes virus 8. Chronic stimulation of lymphoid tissue also increases the risk of lymphoma development. Persistent infection with viruses like the Epstein-Barr virus, our old friend, and the cytomegalovirus, another virus that we've talked about here, also predisposes people to the development of lymphoma. Immunodeficiency includes HIV infection, transplant recipients, and those with genetic immunodeficiency disorders. Drugs. Tumor necrosis factor alpha inhibitors are associated in particular with T-cell lymphoma. Chronic immunosuppression, as mentioned before, in post-transplant patients of both solid organ transplant and bone marrow increases the risk of lymphoma. And then autoimmune diseases like inflammatory bowel disease, rheumatoid arthritis, and Sjogren's syndrome have all been shown to increase patients' risk for diffuse large B-cell lymphoma. And then geographic location. T-cell lymphoma incidence is high in Southern Asia and some parts of Latin America. When we're talking about the ocular manifestations of lymphoma, most of the manifestations occur in the periorbital area. In the MRI image that we see at the top of the screen, you can see one eye is slightly proptotic or it's pushed forward, and you can see a large mass where periorbital fat should be, but is actually a lymphoma. Most commonly, though, it'll appear as a salmon patch lesion on the conjunctiva, which we see on this bottom image here. Or it can also, like I mentioned, appear in the orbit or the lacrimal gland. The evaluation and management of lymphoma. Diagnosis begins with direct and indirect ophthalmoscopy, hematological analysis, imaging studies, and biopsies. Treatment is really directed at the underlying disease and often consists of some combination of chemotherapy and radiation therapy. Patients may require a paracentesis where aqueous humor or vitreous humor is withdrawn from the eye and sent off for analysis in the laboratory. Our nursing considerations, again, include educating the patient about systemic diseases and their ocular manifestations is really essential to care. We're going to see a multidisciplinary approach, including nutritional consultation, psychological support, and possibly socioeconomic assistance for the patient and the family. Marfan syndrome. Marfan syndrome is an autosomal dominant disorder of the mesenchyme expressed as an abnormality of the connective tissue in skeletal, muscular, cardiovascular systems, as well as the eye. Its pathophysiology of Marfan syndrome it's truly a complicated process. Fibrillin 1 is a regulator of transforming growth factor beta bioavailability, which in turn can lead to inflammation, fibrosis, and activation of specific matrix metalloproteinases. Cystic medial degeneration of the aorta occurs when an accumulation of mucopolysaccharide cysts leads to the loss of vascular smooth muscle cells. Tissue weakening is due to the increased release of those matrix metalloproteinases, cytokines, chemokines, prostaglandin derivatives, and elastic degradation fragments. These factors, in conjunction with decreased collagen, reduce tissue structural integrity. Its etiology. Marfan syndrome is largely an inherited trait. There have been rare case reports described where people have a recessive fibrillin 1 gene mutation. Most individuals with Marfan syndrome have an affected parent, but 25% of patients develop the disease as a result of a de novo mutation involving that fibrillin gene, FBN1, encoding the connective tissues. But largely, this is what we need to remember. Tissue weakening occurs in part related to collagen deficiencies, and this affects the eye. So what are we going to see in the eyes of a patient with Marfan syndrome? The most common thing that we're going to see is subluxation of the crystalline lens, and that can be seen in this lower right-hand photograph here. The black space is actually the vitreous behind the eye, no light reflecting, and then this little circle that's sort of sunsetting away is that patient's crystalline lens. Poor pupil dilation as a result of just poor muscle tone. A flat cornea, which we see here. Note that this patient has very little anterior chamber space. Their cornea and their iris are likely touching. These patients, as a result of, again, tissue weakness, can become relatively high myopes. That is a patient whose prescription is usually greater than a -6. And along with high myopia comes the risk for a retinal detachment, which is this top image here. And you see sort of this turbidity of the retina. Instead of being a flat image, it's raised off of it. So these patients often need a lot of assistance and help, either with cataract surgery, retinal detachment surgery, scleral lenses. The evaluation and management of Marfan syndrome is based on slit lamp microscopy and direct and indirect ophthalmoscopy. Management of retinal detachment may require a vitrectomy with a gas fluid exchange, use of silicone oil, scleral buckling. A detached or a subluxated lens will also require cataract surgery, implantation of a subcapsular lens or an anterior chamber lens to correct the vision. Sometimes we leave these patients aphakic and just give them very big glasses. Our nursing considerations, of course, close collaboration among clinicians of diverse disciplines is required to manage the broad spectrum of clinical problems that we see in these patients, which includes visual impairment, cardiac issues. So again, psychological support, patient education are going to be key for these patients. Multiple sclerosis, or MS. is a chronic, progressive, idiopathic, demyelinating disorder of the central nervous system. It's characterized by intermittent disturbances of neurological function, and roughly 25% of these cases present with monocular visual loss accompanied by periocular discomfort. Here we see the demyelination in this MRI. Its pathology and etiology. For pathology, focal inflammation resulting in macroscopic plaques and injury to the blood-brain barrier, and then neurodegeneration with microscopic injury involving different components of the CNS, including axons, neurons, and synapses. The exact etiology of MS is unknown. Factors involved in pathogenesis broadly group into three categories. Immune factors. Dysimmunity with an autoimmune attack on the central nervous system is a leading hypothesized cause of MS. There's also environmental factors to be considered. Vitamin D deficiency has been considered a possible etiology, largely because of the noted predisposition of MS to affect people that live in the northern hemisphere at higher latitudes. And then, of course, there's genetic associations. Heritability is estimated between 35 and 75%. So when we're talking about the ocular manifestations of MS, really what we're going to see is papilledema, optic neuritis. Patients will complain of double vision. Sometimes they'll present with nystagmus as well, or sort of the shifting of the eyes, as we've seen earlier. To illustrate this, all the way on the right here, we have what is a very normal optic nerve. This is what a normal optic nerve looks like. Margins are clean, it's well defined. And then these next two photos, the one in the middle, you can see that the margins start to blur. It looks inflamed, it looks angry. And then all the way to the left, same thing, blurry margins. It's really difficult to distinguish a cup to disc ratio, and we start to see a hemorrhaging as a result of it. These patients also will talk about ocular discomfort. They're in pain, they've got headaches, that sort of thing. So our evaluation and management of multiple sclerosis will involve a few things. Usually diagnosed by direct and indirect ophthalmoscopy. This is generally the case for everything in ophthalmology. And the ophthalmic evaluation may lead to further evaluation of the patient. A lumbar puncture is the diagnostic aid most commonly used. Some people will talk about visually evoked cortical potential test. Is used to verify complaints of reduced visual performance and to identify the site of the disorder. Other tests performed for diagnosis of MS can include CAT scans, MRIs, and treatment of the ocular systems is kind of unnecessary. Steroids can help to mitigate the problems, but they tend to be sort of transient in nature when we're talking about the eyes and resolve with the patient's systemic MS therapy. Our nursing considerations, having a good knowledge of systemic diseases and their ocular manifestations, again, is going to help in planning care. Talking to patients about steroid management, providing psychological support, and ongoing patient teaching are among the measures to be considered when treating patients with MS. Myasthenia gravis is an autoimmune disease of the neuromuscular junction affecting acetylcholine receptors, causing fluctuating weakness of certain skeletal muscles. It can occur at any age, but it is most commonly seen between the ages of 10 and 65 and affects women more frequently than it affects men, usually the peak age being about 20 to 30 with women, and in men over the age of 60. Ocular involvement usually involves the eyelids or the extraocular muscles, and that presents in about 90% of the cases during the first 2 years of onset. The pathology of myasthenia gravis is dependent on the type of antibodies that are present. The antibodies can be of the IgG1 and IgG3 subtype. They bind to acetylcholine receptors present in the postsynaptic membranes of skeletal muscles and activate the complement system, leading to the formation of the membrane attack complex, or the MAC. If the antibodies are of the IgG4 subtype and do not have the complement activating property, they bond to agrin LP4 MuSK protein complex in the neuromuscular junction, whose primary function is the maintenance of the neuromuscular junction, including the acetylcholine receptor distribution and clustering. The etiology of myasthenia gravis is similar to other autoimmune disorders. It occurs in genetically susceptible individuals, and precipitating factors include conditions like infections, immunizations, surgeries, and drugs. So, when we're talking about ocular manifestations of myasthenia gravis, the hallmark is bilateral ptosis, which we're seeing here. This patient has very droopy eyelids. What's interesting in this case is this patient is being treated with something that we call the ice pack protocol, where they hold an ice pack over their eyes. So when extraocular muscles are also involved, we're going to see limited eye movement, and occasionally patients will also present with diplopia because they can't fuse the images of their eyes as a result of muscle laxity. So the ICE test is used to rule out the disease if there has been evidence of improvement of muscle strength after the ICE test. Usually this is pretty good confirmation that a patient has myasthenia gravis. A presumption of the condition should be made for any patient with ptosis or diplopia of an uncertain etiology that is variable or worsens with fatigue. Due to the systemic involvement of myasthenia gravis, a neurological referral is typically recommended. Management focuses on avoidance of drugs that may cause muscle relaxation, including aminoglycoside antibiotics, cardiovascular agents, muscle relaxants, anti-seizure drugs, and psychotropic medications. Our nursing consideration, again, is really going to focus on patient education to help the patient understand precipitating factors that are going to exacerbate their condition. And then thinking about lifestyle changes that are going to be needed to prevent that exacerbation. Patients are encouraged to avoid drugs that interfere with acetylcholine uptake, and psychological support is also provided due to lifestyle changes that may need to be required. So let's talk about the ocular manifestations of polycythemia vera, which is a blood dyscrasia of hyperviscosity characterized by an increased number of red blood cells. Typically seen in adults over the age of 60, and sometimes, but rarely, in adults under 20. Usually affects men more than women, and in most cases it can be genetically based. When we're talking about the pathophysiology of this condition, we're going to talk about bone marrow of patients with polycythemia vera contains normal stem cells and contains abnormal clonal stem cells that suppress normal stem cell growth and maturation. And then the etiology of the disease process appears to be neoplastic proliferation. There's a signaling defect leading to abnormal response in growth factors, and the abnormal clonal line interferes with the normal lineage of proliferation. Signs seen in the ocular vessels are related to an increase of blood viscosity with slowing of circulation, resulting in hypoxia of the eye. Insufficient oxygenation of retinal tissue may account for the retinal manifestations that we're about to talk about. So our ocular manifestations of polycythemia vera include a dusky cyanotic retina. Remember, we're seeing slowed tissue perfusion, and so in patients who are hypoxic, we're going to see kind of that dusky color, that blue color. And here we see that in this lower image. The retina kind of is not the typical color that you would see in a retinal image. You'll see venous dilation, retinal hemorrhages. Again, we're seeing that here. We're seeing this particular around the nerve, but in the upper left photograph, again, you can see these red blotches. Those are retinal hemorrhages. Cotton wool spots, those are these bright white spots that look like wool. we can see vein occlusions, papilledema. Again, in this photo, we see the swelling of the optic nerve. And patients will present with blurred vision and, in very extreme cases, retinal vein occlusions. So our evaluation and management of polycythemia vera, again, evaluation and management. We're going to use direct and indirect ophthalmoscopy. And then symptomatic relief by phlebotomy to lower red blood cell count and reduction of the total blood volume. Our nursing considerations, again, patient education, and helping the patient understand controlling the underlying disease process. They'll have to follow up on sort of knowing what signs and symptoms of the disease as it progresses, and again, psychological support. Sickle cell disease might be one of the more interesting ones that we get to see in ophthalmology. It's an inherited disorder of an abnormal hemoglobin that causes the red blood cells to adopt a sickle shape, usually under conditions of hypoxia or acidosis. The Centers for Disease Control estimates that approximately 90,000 to 1 million Americans are actually affected by the disease. Pathology shows us that this genetic mutation described causes polymerization of the hemoglobin molecule that alters the erythrocyte shape and its ability to deform. There is increased adhesion of the erythrocytes, followed by the formation of a heterocellular aggregates, which physically cause small vessel occlusion and result in local hypoxia, which can be quite painful. Its etiology, sickle cell, is caused by mutation in the hemoglobin beta chain, in which glutamic acid is substituted with valine at position 6 on chromosome 11. So ocular manifestations. Again, this is a disease that is affecting blood cells, and when we're talking about blood, we're going to be talking about the vasculature of the retina. Ocular involvement, the signs and symptoms tend to be mild and asymptomatic. Sickle cell disease primarily affects the retina, causing peripheral retinal vascular occlusion, which you're seeing out here in these images of a fluorescein angiogram. You see what we call vesicular dropout in this patient, where they're losing perfusion to their peripheral retina. Typically, we could, in these wide field images, we would see blood flow going all the way out into the periphery. And it can cause vitreous hemorrhages, which is where blood floats into the vitreous. And these little shapes that we're seeing on the photo to the left, this is called C-fan-shaped neovascularization that can occur. These patients also get salmon patches and a condition called bear tracks within their retina. Visual field loss results as a result of this retinal ischemia. Our evaluation and management of sickle cell disease. In general, diagnosis of this disease is made by positive sickle cell electrophoresis testing. Ocular complications are confirmed, again, by direct and indirect ophthalmoscopy. There's really not a lot of prophylactic treatment that's been shown to be effective, and treatment is really related to the stage of the disease. Management of sickle cell disease usually involves blood transfusion, treatment of symptoms, treatment of pain. Photocoagulation therapy or laser procedures can be used to treat ischemic areas of the retina and to lower the risk of neovascularization of vessels. For patients with intractable vitreous hemorrhages, we can talk about surgical options like a vitrectomy. And there has been a few studies that have shown that these patients also respond to anti-VEGF intraocular injections. Our nursing considerations, getting a good patient history, super important, making sure that these patients are dilated really well, because again, we want to see out into the far periphery of the retina. Ensuring that these patients, because of that neovascularization, we want to be measuring intraocular pressure, making sure that stays low, and then making sure that we're providing adequate oxygenation to these patients, and patient education and psychological support. Sjogren's syndrome is a chronic inflammatory disorder characterized by insufficient moisture production of the lacrimal and the salivary glands. And we know the lacrimal gland is super important in producing moisturizing tears for the eye. Its pathophysiology is characterized by lymphocytic infiltrates and the destruction of the salivary and lacrimal glands and systemic production of autoantibodies to the ribonucleoprotein particles. The infiltrating cells, which are T and B cells and dendritic cells, interfere with glandular function at several points. Destruction of glandular elements by cell-mediated mechanisms, secretion of cytokines that activate pathways bearing the signature of type 1 and type 2 interferons, production of autoantibodies that interfere with muscarinic receptors, and secretion of metalloproteinases that interfere with interaction of the glandular cell with its extracellular matrix, which is necessary for efficient glandular function. As the process progresses, the mucosal surfaces become sites of chronic inflammation and the start of sort of just this vicious circle. Its etiology, which is really the case with a lot of autoimmune disorders, is really unknown. Lab studies, as well as some indirect epidemiological evidence, implicates viruses, including our friend the Epstein-Barr virus, as participants in disease pathogenesis. So the major finding that we're going to see in patients with Sjogren's syndrome is something called keratoconjunctivitis sicca, or chronic dry eye syndrome. It's present in 90% of the cases in patients with this. Foreign body sensation is also kind of an early indicator of the process. And so when we're looking at the eye in the first image here, the top image, we're seeing that there's a lot of dryness going on. We're seeing that the conjunctiva is inflamed, it's highly vascularized, and this patient's cornea is starting to get damaged as a result of that lack of moisture. The bottom image is the same eye, but with fluorescein staining, and we're seeing a lot of fluorescein uptake in the cornea. If this patient had a typical tear process, we would not see that. We would see a little bit of staining, but it would quickly go away within a few seconds. So the evaluation and management of Sjogren's syndrome, we're going to really rely on a Schirmer tear test as being probably the most valuable thing we're going to do to diagnose Sjogren's syndrome. Rose Bengal staining and measurement of tear osmolarity are also good tests. The goals of managing the disease are to preserve corneal tissue and the existing tears that are on the eye. Ocular lubricants are commonly prescribed to replace tears. Other measures include application of clear occlusive patches, punctal occlusion either with plugs or cautery, reducing room temperatures, and using room humidifiers. Procedures such as lateral torsorrhaphies, where you sew the eyelids slightly together to protect the cornea, result in an excellent prognosis for these patients, but artificial tears are going to be needed indefinitely. Our nursing considerations, again, patient education, corneal tissue preservation, and reminding those patients tear replacement is important. Psychological support can also be helpful. Syphilis is a systemic inflammatory venereal disease characterized by cutaneous lesions that may involve other organs. Its pathophysiology, the classic primary syphilis presentation is a solitary, non-tender genital chancre in response to the invasion of T. pallidum. However, patients can have multiple non-genital chancres, such as those on their digits, nipples, tonsils, their oral mucosa. These lesions can occur at any site of direct contact with the infected lesion and are accompanied by tender or non-tender lymphadenopathy. Even without treatment, these primary lesions will go away without scarring. If untreated, primary syphilis can progress to secondary syphilis, which has many clinical and histopathological findings. Its etiology, Treponema pallidum, was identified as the agent that causes syphilis in 1905 by German scientists, and 1 year later the test to diagnose this infection was developed. Its genome was sequenced in 1998, and the Treponegenesis is a spiral-shaped bacteria with a rich outer phospholipid membrane that belongs to the spirochete order. It has a slow metabolizing rate, as it takes an average of about 30 hours to multiply. Let's talk about those ocular manifestations of syphilis. So they really present according to the phase of the disease. Lymphocytic infiltration in prelimbal conjunctiva can be noted. But really, we're going to see sort of secondary effects of syphilis on the eyes. The iris is sort of more susceptible in acquired syphilis cases compared to the choroid, which is more involved in the congenital form of the disease. Both acquired and congenital forms cause potentially significant visual impairment. So on this iris, we see these little rubella that are common in the irises of people with syphilis. They can develop something called Argyll-Robertson pupil, which is sort of this tonic pupil that doesn't have a light response. Instead, it has an accommodative response. So in the primary stage of syphilis, a chancre may be noted on the eyelid or on the conjunctiva. The following manifestations occur in the secondary stage of the disease. Eyelid, skin rash, eyebrow, eyelash loss, interstitial keratitis, that's corneal involvement, uveitis progressing to secondary glaucoma. Here we see sort of an inflamed optic nerve, another inflamed optic nerve. Disseminated chorioretinitis and corneal opacification. Optic atrophy is present in both primary and secondary stages of the disease. So again, syphilis is often called the great pretender. It can present as a lot of different things. In patients, it's important to sort of get a very good history on them when they start presenting with symptoms of conditions like uveitis. So in our evaluation and management of syphilis, again, slit lamp microscopy and direct and indirect ophthalmoscopy are always going to be in there. They're going to be part of this. A positive serologic testing confirms syphilis approximately 14 days after the appearance of a chancre. Adequate treatment of primary syphilis with penicillin prevents ocular disease. Ocular complications may be managed by local anti-inflammatory ocular therapy or systemic corticosteroids to minimize damage to the retina and the choroid. Anterior uveitis may be managed with local mydriatics, dilating medications, and steroids. And local steroid therapy has proven to be effective for interstitial keratitis or that corneal involvement. Our nursing considerations, we're going to have to do some patient education regarding venereal disease as our primary goal to prevent the spread of syphilis. Early recognition of the disease aids in selecting appropriate therapy to limit those further complications. So Tay-Sachs disease is a hereditary autosomal recessive disease characterized by the progressive destruction of nerve cells in the brain and the spinal cord. It's rare. Usually it affects Jewish children of Eastern European descent. It causes impaired mental development, progressive muscular weakness, seizures, and unfortunately early death. Its pathophysiology, Tay-Sachs disease is caused by a deficiency of the enzyme beta-hexosaminidase, or hex-A, which is responsible for GM2 ganglioside degradation. Its etiology, Tay-Sachs disease, is an autosomal recessive disorder, again caused by a mutation in the gene hexa, or HEXA, which encodes the enzymes beta-hexosaminidase A. Hexa is located at 15q23. More than 130 mutations have been identified so far and include single gene deletions, substitutions, insertion, splicing, alteration, duplications, and complex gene rearrangements. The most typical sign of Tay-Sachs disease is a macular cherry red spot, which you see in this photograph here. a dark red spot in a very pale fundus. It presents in 90% of the cases, and it causes early visual deterioration and impairment of the visual acuity. Other ocular manifestations is pigmentary retinopathy, and consequently the end stage of Tay-Sachs is blindness and death. Tay-Sachs disease is it's a rough disease. These are children that we'd be seeing. The definitive diagnosis of the disease is an enzyme assay of the patient's cerebrospinal fluid. Kids are tough to evaluate, but again, we'd be using direct and indirect ophthalmoscopy, fluorescein angiography if it's possible, fundus photography. Sometimes an ERG or an electroretinographic study can be performed to determine the extent of the ocular involvement. The importance of ophthalmic evaluation really lies mainly in cases of severe neurological deterioration in infants and children. Our nursing considerations, our nursing plan is going to see a lot of parental support, a lot of family teaching, and then suggestions of genetic counseling. Thyroid disease, specifically hyperthyroidism, is a systemic disease characterized by a disturbance of the thyroid gland. The clinical syndrome of an overactive thyroid gland is termed hyperthyroidism. An estimated 2% of women and 0.2% of men suffer from hyperthyroidism, with the highest frequency in both women and men occurring between the ages of 30 and 50. So here we're going to talk about the pathophysiology and etiology of Graves' disease, which is an autoimmune disease, unsurprisingly of an unknown etiology. It's particularly caused by the production of thyroid stimulating immunoglobulins that bind to the TSH receptor and mimic the effects of thyroid stimulating hormone. Graves' disease presents with two extrathyroidal signs that are not typically seen in other forms of hyperthyroidism. Impaired venous drainage from the orbit causes increased fatty deposits and fluid to form in the retroorbital tissue. Swelling leads to the optic nerve compression and eventually impairs the vision. So our ocular manifestations are going to be something called exophthalmos or proptosis. It's the classic feature of Graves' disease that's characterized by an abnormal protrusion of the eyeball. The protrusion is usually bilateral, although it can be unilateral or asymmetric. Multiple ocular manifestations are noted, such as orbital edema, swelling of the orbital contents, optic nerve compression. Again, the eye is being sort of pushed forward and squeezed on the sides, which can cause that nerve compression. We can see extraocular muscle palsies, loss of vision, ptosis, thin, very dry eyelids, lid edema, lid lag or lid retraction, an inability for the eyelids to actually close. Diplopia, double vision, again, we'll see that when the muscles of the eye start to get involved. Keratitis, corneal ulcers as a result of that lag ophthalmos, because the cornea is going to be exposed to the environment without adequate blinking to remoisturize it. And because of nerve compression, we'll see glaucoma in these patients as well. So evaluation and management of hyperthyroidism or Graves' disease in patients. Common tests performed to diagnose this are, again, direct and indirect ophthalmoscopy. We can also do orbital ultrasounds. In general, either thyroid function testing or CAT scan confirms thyroid disease. The ocular treatment of choice includes systemic steroids, tapered to a maintenance dose. Lubricants are prescribed to protect corneal tissue. Local radiation is used in very severe cases. Management of thyroid disease includes referrals to endocrinologists as well as surgery for optic nerve decompression, unresolved diplopia or double vision, and persistent eyelid malposition. Nursing considerations, compliance and adherence of anti-thyroid drugs are really our primary goals for maintaining normal thyroid levels. Patients are encouraged to maintain optimal vision by checking visual acuity often and protecting the cornea to prevent ulcer formation. Let's talk about toxo or toxoplasmosis. It's a parasitic infection caused by an obligate intracellular organism called Toxoplasma gondii. It is highly prevalent in warm and humid climates. Immunocompromised people, such as those with HIV, AIDS, patients undergoing chemotherapy, and pregnant women are highly susceptible to contracting toxoplasmosis. Its pathology, again, obligate intracellular growth of tachyzoids results in direct cytopathic effects, cellular inflammation, and necrosis. Etiology. Humans can contract Toxoplasma gondii infection in 4 ways. 1, foodborne transmission, so ingestion of the tissue cysts via consumption of undercooked or raw meat. 2, zoonotic transmission, ingestion of oocytes via consumption of food and water contaminated with feline feces. 3, vertical transmission, infected mother causing congenital infection through the placenta. And then 4, transmission via organ transplantation or a blood transfusion. So this disease has a variety of clinical manifestations ranging from subclinical courses to generalized infections with fatal outcomes. Proliferation of the parasites in retinal cells results in death of those retinal cells, which leads to foci of necrosis surrounded by an intense mononuclear inflammatory response. So we're going to see chorioretinitis in these patients, very often bilateral macular lesions and congenital toxoplasmosis. We'll see uveitis and localized area of necrotizing retinitis. These patients can have blurred vision and retinal detachments. So in this upper left-hand photograph, we see this area of necrosis. Note sort of the black tissue exposure of the underlying choroid. And this would sort of be presumed ocular toxoplasmosis. And this lower photograph, which is blurry, admittedly, is showing us something called vitritis, or an inflammation of the vitreous. And then underneath that, we can see sort of this area, this bright white spot, which is the development of that macular lesion that we talked about, that we see in cases of congenital toxoplasmosis. We'll see bilateral macular lesions. So evaluation and management of toxoplasmosis, say it with me, direct and indirect ophthalmoscopy are standard to diagnose ocular complications. We'll also see positive laboratory tests of antibodies as our sort of definitive diagnosis. Pharmacological management of the disease includes chemotherapy, antimicrobials, and corticosteroids. Other procedures really consist of photocoagulation, laser therapy, cryotherapy, cold therapy, usually minus 85 degrees to sort of kill microorganisms there, and possible vitrectomies. Our nursing considerations. We really want a detailed medical history. It's super beneficial in a differential diagnosis. We want to teach the patient about prevention as being most important to minimize human contact with the parasite. Pregnant women should not come in contact with animal feces and sand or litter boxes and soil, and sand or litter boxes in the vicinity of a pregnant woman should be covered. Same thing for our immunocompromised patients. Patients should be educated in how to handle meat with care and should avoid ingesting uncooked meat. Assessment of visual acuity helps with early identification of potential ocular problems. So tuberculosis is going to be the last condition that we talk about, and we'll close out this presentation before you take your post-test. So TB is a chronic granulomatosis infection caused by either bovine or human tubercle bacilli. Primary tuberculosis occurs in patients not previously exposed to the infectious organism. Post-primary disease is usually seen in patients with impaired immunity caused by HIV, AIDS, diabetes, patients on long-term systemic steroid therapy, or advancing age, or possibly malnutrition. Pathophysiology. Although usually a lung infection, tuberculosis is a multi-system disease with protean manifestations. The principal mode of spread is through the inhalation of infected aerosolized droplets. Our etiology: M. tuberculosis causes tuberculosis. M. tuberculosis is an alcohol and acid fast bacillus organism. It is part of a group of organisms classified as the Mycobacterium tuberculosis complex. The ocular manifestations of tuberculosis. We're going to see uveitis as our common clinical presentation. We can see multiple miliary nodules appearing on the fundus. That can be noted. That's seen here in this lower photograph, sort of these discolored spots that we're seeing in the fundus of this patient. Other ocular manifestations are chorioretinitis and large solitary choroidal granuloma, which may be mistaken for a tumor. And so in uveitis, we can see something called synechii in patients, and that's sort of what you're seeing here in this upper picture of this pupil, where parts of this patient's pupil can dilate, other parts cannot dilate, and you sort of get this odd shape. That's a common finding in uveitis. So, tuberculosis, again, we're going to talk about direct and indirect ophthalmoscopy are used to evaluate ocular complications. In general, a positive sputum test or tissue test for Mycobacterium tuberculosis indicates presence of the disease. Diagnosis of ocular tuberculosis is based on indirect evidence. Findings of intractable steroid-resistant uveitis require further evaluation for possible systemic causes. Uveitis caused by a tubercle bacillus is one of several uveal inflammations curable with antibiotics. So we'll see antibiotic therapy for these patients that will resolve their uveitic symptoms. Treatment consists of systemic anti-tuberculosis drugs. Our nursing considerations: patients are going to require follow-up by a public health agency for contact tracing. We're going to need to do ongoing patient teaching, in particular about adherence to the medication regimen. That is going to be our primary goal. So over the course of these last two presentations, we've talked about a lot of systemic disorders with ocular manifestations. Nurses are often involved in multidisciplinary care of patients, and a systemic disease with ocular complications offers unique challenges and requires input from a lot of subspecialists, including those in infectious disease, endocrinology, rheumatology, neurology, hematology, cardiology, and ultimately primary care. Patients with systemic diseases often require interventions from multiple nursing fields, including public health, surgical, ophthalmic, or any number of nurses working within the field. Potential loss of vision secondary to another condition exacerbates fear and a feeling of helplessness in a lot of these patients. We can provide them a lot of comfort. We can provide them with a lot of peace of mind knowing that we can take care of them. Nurses' care and ability to provide information throughout the disease management helps lower that anxiety level in these patients, and it can really help optimize care outcomes. I want to thank everybody that stuck with me through this whole thing. I really appreciate your help with this project. It really does mean a lot to me. I'm very passionate about ophthalmology and nursing. So thank you. Good luck on your post-test. Remember to take the post-test survey that's on the website. And again, if you have any questions, please reach out to me. Thanks. Again, here's just some references. Big one is the Essentials of Ophthalmic Nursing from the American Society of Ophthalmic Registered Nurses. They've been super helpful implementing a lot of the information that I've been able to give you folks. And if you've heard any barking during this entire presentation, It was this guy. This is Clarence. He stuck with me through the whole presentation too. And thank you again.